Okay. Good evening, everyone. We were just testing our screen share. I'm sure everyone can relate to those challenges. So today is Monday, July 27th. I don't know about you guys, but I have no idea where July went. But I'm happy to be here and I'm looking forward to August and all that that will bring us. So a few housekeeping things before we jump into the good stuff. I'm Anne from podiatrymeetings.com. If you've never seen me, hello. We use Zoom webinar for these. So it's very similar to Zoom meeting if you've had a Zoom meeting, which I assume you have. The difference is we have the Q&A function in Zoom webinar. So tonight when you have questions, and I encourage you to ask multiple questions, um, as many as you want throughout the event. If you find that Q&A box, for me, it's hidden along the bottom of my Zoom screen. Like I have to hit the more icon to find that Q&A box, but it says Q and A with a question mark. So type your questions in there, um, and you can type them in when they occur to you, and then you can type in multiple questions. That helps me keep things organized, and we'll get all those questions answered at the end so I can check them off as I go. Um, if you have any issues, like technically or something you want to share with the class, you can put that into the webinar chat, and I'll be monitoring that in case there's anybody that needs any help. And then the other cool thing about Zoom webinar is the reactions button. So for me, that's along the bottom of my screen. There's the word react with a heart. And if you like my bangs, I would love for you to send up a reaction button just to test to make sure you know how those reactions are working. Good. I love it. Okay, good. We've got plenty of people paying attention. That's awesome. So again, tonight, put your questions in the Q&A. We'll get those answered at the end, and any technical issues or things you'd like to share with the class that can go in the chat. So tonight I am here with our sponsor, which is ToeFX. And if you don't know ToeFX, they've made a huge splash in our industry over the past few years. Um, I remember when I first started noticing their content, it was all over LinkedIn. And Dr. Van Am was like posting all kinds of opinions and editorial content, and I just loved it. And I was like, who are these people? And then I ran into her at a show and fell in love with her. So, anyways, they have a revolutionary light device that treats onychomycosis. And so we're going to talk about that tonight. And I am joined by Dr. Monica Yazdanian. She is the CEO and co-founder of ToeFX. She drives the company's strategy and growth initiatives. She holds a PhD from Cornell University and a JD from Western University, bringing a unique blend of scientific, legal, and entrepreneurial expertise to her leadership at ToeFX. She previously served as director of the Forge, McMaster University's startup incubator, and as director of research and development at a solar cell laboratory at the University of Toronto. So, welcome, Dr. Yazdanian. Thank you for being here.
Oh,
And we also have my friend and colleague. I have known her since New York all the way to Florida. So, welcome, Dr. Patricia Nicholas. She's a graduate of the New York College of Podiatric Medicine. She ran multiple successful medical practices on the North Shore of Long Island for the past 20 years. She was the first minority president and the second woman president of the New York State Podiatric Medical Association, and she made advancements to population health agenda. She's an active member of APMA. She's chaired the Ethics Committee, Awards and Recognition Committee, and Membership Committee, Public Education and Information Committee, among many others. Just reading this bio, and this is like the third time I've read it today, all I hear in my head is that quote saying, if you need something done, give it to a busy person. Like, all on top of running a practice. So she serves as chair of the podiatry committee for a state of New York Workers' Compensation Board. She's an adjunct clinical professor at the New York College of Podiatric Medicine, past president of the Caribbean American Medical and Scientific Association, and her heartstrings were tugged with the earthquake in Haiti in 2010, and soon after founded the Kindest Hearts Foundation. Thanks to the generous donations of her friends and colleagues, she built a school for over 200 students and manages a staff of over 50 employees. The foundation also runs a medical clinic. So Dr. Nicholas came to Florida, the Fort Myers area, in 2019 with her husband and is now practicing at the Orthopedic Center of Florida. So welcome, Dr. Nicholas. It's very good to have you here.
Thank you so much. Nice seeing you again, Anne and Monica. Nice to be here.
Wonderful. Well, I am managing the slide presentation tonight. So I'm going to mute myself and turn off my camera, so that you're not distracted by the chaos happening on my end. But I'm going to advance the slides. So first I'm going to test my screen share. If y'all can see my slides in just a second, just give me a reaction button. And then Dr. Nicholas and Dr. Yazdanian, if you just want to say next slide when you're ready for me to move on. Okay. Let's see if I can do the technology.
And am I able to share my screen as well?
Yes, would you like to do that first?
I could do that first and then turn you over to the slides.
Sure, you got it. I think I've made you co-host, so you should be able. Yep, you are.
Thank you.
While you're doing that, I've totally forgot my favorite part of the webinar, so I'm going to ask Dr. Nicholas, as a child, what did you want to be when you grew up?
The doctor. Never changed
Really?
my mind. Yes, I wanted to be a doctor and a nun. At the same time, didn't know how I was going to do it. But I grew up to be a doctor, the nun part, forgot about it. I've been married 35 years. So
That's amazing.
A little bit of both to match
Yeah.
it up
yes,
to
it's
it.
my shadowable work, yes.
Good for you. Okay, so we see your screen, so you are good to go. Like I said, I'm going to mute myself and turn off my camera, but I'm still sitting right here.
Fantastic. Hello, everyone. Good evening. Thanks for having us. We're really delighted to be sponsoring this session, especially working with one of our favorite people, one of the most dynamic people, amazing podiatrists and best speakers out there. That would be Dr. Patricia Nicholas. So really happy to be sharing this with you. I'll just take 10 minutes. I would like to tell you a little bit about the clinical study that TOEFX spent a lot of time on. So I'm Monica, again, Dr. Monica Yazdanian. I'm the CEO of TOEFX. This study took a long time, and we'd really like to tell you a little bit about it before turning it over to Dr. Nicholas, who will tell you all about how she has been using light therapy in her practice. So this is actually, to the best of our knowledge, this is the largest study to date of light therapy for severe onychomycosis. And it was done by Dr. Alexander Rabinovich. Full disclosure, we sponsored it, and I'm going to tell you a little bit about these results. So it's a 3-year longitudinal study of light therapy, and I'll tell you whatever I can in about 10 minutes, and then obviously you're free to ask questions at the end. Okay, everyone on this call, I'm sure, knows the clinical forms of onychomycosis. We were looking at the worst of the worst. So I think that, and I'll get into this a bit, the inclusion and the exclusion. What really set this study apart is if you look at most onychomycosis studies, if you dig into the inclusion criteria and the exclusion criteria, you will find the worst stuff is often excluded. Not always, but it's very often excluded. Look up your favorite topicals and see what kind of stuff they didn't include in the study. So we took the worst. We took the totally dystrophic nails that looked something like this, the second one in the queue. Um, I'm sure everybody knows challenges in treating severe cases. Most studies don't focus on them because they're very difficult. You've got nail thickening, difficulty reaching the infection, which lives under the nail plate. The nail matrix can be damaged, all the terrible stuff. So there are a lot of challenges, and we wanted to see if we could rise to this challenge. I'll skip this stuff because I'm trying to just keep this brief. What happens with severity in onychomycosis? Two things. So aging is one of the major determining factors of what really takes an infection over, kicks it over into the severe. Just the longer you have it, the worse it starts to get. And as I said, it's a self-perpetuating cycle. You weaken the keratin matrix in the nail, making it a more and more attractive target for these fungal organisms. So aging, you just decrease the circulation. So poor blood flow reduces immunity, reduces nutrients. You get a weakened immune response. Self-perpetuating cycle, as I said, the fungal organisms, they're just really vicious. So they'll produce these keratinases, other enzymes, steadily break down this matrix, and then the colonies will find these nooks and crannies and take up residence essentially for eternity in all of these nails. So you get an immune response, a localized inflammation response to the fungal colonization. It leads to thickening of the nail and the surrounding tissues, but unfortunately, the chronic inflammatory state, it just contributes to further nail dystrophy and then weakens the nail even more. So this is really a chronic problem, and that's why we wanted to make sure our study was covering a long period of time. So everyone knows the onychomycosis treatment options. We're looking at the light therapy. So the study aim here was to evaluate the efficacy of the novel light therapy, and we included not just severe cases, but non-model patients with comorbidities who are often excluded. And again, the reason is we were really trying to design or the study so that it's including the typical patient who's walking into your practice. Because a lot of people with just a spec, they may choose to use Dr. Google or use Dr. Amazon. Obviously, maybe they shouldn't be, but if the people with the comorbidities, they have a lot of troubles, and they're the people realistically walking into practices. Uh, Unique aspect. So I talked a bit about the severe focus on severity. Why light therapy for specifically for severe cases? A lot of patients who are severe may be seniors who could be hesitant to add a terbinafine pill to their regimen, or they may have difficulties applying local treatments daily for 6 months. So this is a medical device. It's not a drug. It's not metabolized. It's not systemic. So it's non-toxic and safe. Some characteristics, so 101 patients, 165 nails, 80% of patients had the infection for 5 years or more, and I think it was 70 or 65% had it for 10 years or more. 90% of the patients in this study had matrix involvement, dermatophytomas, less than 2 millimeters of clear nail. We did allow comorbidities, including heart disease, psoriasis, poor circulation, and other things too. I'm going to skip just to Dr. Nicholas will tell you more about how she works with light therapy in her practice. I will skip right to how we evaluated it. So we looked at the clear nail coming out, and we were measuring this graph paper using custom software to account quantifiably for the measurement. And we saw success as 3 millimeters of clear nail or total clearance. Secondary output, we were looking for, or endpoint, sorry, we were looking at mycological cure. Skipping to the conclusion. So 73% of the nails achieved the success criterion. That jumps to 81% when you're looking at the severest cases. And that is 53% achieved over 6 millimeters of clear growth. So over the 6 months, this is the time that we're looking at, we were seeing a median growth of 5.7 millimeters. Over 12 months, that we actually did not administer the treatment every 2 weeks, but we we spaced out the treatments just for maintenance, just to see if we could keep the success of the 6 months. And almost every single patient either got better or maintained, rather than do what they usually do, which is relapse. I'd love to tell you more because there's lots to say about this study, but it's coming out in JAPMA, I think next month. So we're really excited for this publication. And thanks for letting me tell you a little bit about the clinical work we've been doing, or clinical studies we've been doing at TOEFX. Thanks so much. And over to you, Dr. Nicholas.
Hi, everyone. I'm going to be talking about how I've implemented TOEFX treatment for my patient in the office. Anne, can you
Yes, I am pulling it up right now. All right. You guys
Am I
can see everything? Super. I love the reaction button. Thank you.
okay? You can move. You'll be able to. I cannot move the slide, so you'll have to move the slide for me,
Yes,
please.
ma'am. Just tell me when to go.
Next. That's fine. We can move to the next one. Okay, move to the next. Next. Okay, so in my practice, the way I do it, when the patient come in, I treat every patient that come in with onychomycosis. They don't just come in for 2FX. So I did the same thing for all patient that comes in. Their chief complaint is thickened yellow nail, or we'll get them scheduled. They'll say patient here for onychomycosis treatment, or they've Google treatment and toe effect does come in if patient comes in Google for treatment for toe effects. They will say, I've heard about toe effects, I want to know more. But before I get to the toe effects treatment with them, I do a regular physical exam, comprehensive exam. I do their pulses, everything. This way I know exactly if they might not be a candidate for toe effects, so I just don't say, yes, you have to do it. I do a full analysis and comprehensive examination with them. So we can go next. Next. Okay, so when we start, no, go back, go back.
Hold
Mm-mm.
on. Sorry. I'll get with the program one day.
Okay. So you're going forward. So we're going back. So when they come in, go all the way back. You almost in the big, yes. Okay, right here.
Thank
So when
you.
you're welcome. So like I said, when they come in, I explain to them because most of them have done topical treatment from the store, either online or their local pharmacy. They say they know, or they say they've gone to a doctor that told them they have fungus, but I don't go by that. And I don't know how much the other practitioner has told them. So I tell them, let's start from scratch. So I tell them about the different options available. And we fought by topical, and I tell them about the topical that they buy over the counter or prescription, about the efficacy rate between 30 and 50%, give or take. And then I tell them about the oral treatment, terbinafine or fluconazole. Then I tell them about surgical removal. Sometimes the nail is so thick, and I'm going to talk about that a little bit, so thick that for my personal clinical judgment, I do not think that if we do not remove that toenail, we're not going to have a good result. So I tell them I recommend that we remove the nail because of the thickness before we do any other kind of treatment. And we do not do laser in the Orthopedic Center of Florida, so we do to light therapy. I explain to them the process, and then of course I take a culture. I do not take a culture if they have known to have fungal infection because another provider has done it before, or if they currently applying some kind of topical. So sometimes I do not do a fungal culture, but almost always I have to say I do a fungal culture on my patients. Next slide. So after we discuss all about the different treatment option, and then I always give the patient a choice. Some of them want to do it on the spot, we'll get there. And some of them, I will say you come back in 2 weeks to discuss your results, and then we can decide what treatment options are for you. But more importantly, that I tell them, no matter how much medication we apply to this fungal nail, no matter how many pills you take, there are things that need to be done to help the process. If you put in your medicated toenail in dirty, full of fungus shoes, there is nothing I can do. That's a failure ready to happen. So I give them a whole list of daily hygiene, food hygiene. I recommend foot spray, topical antifungal spray, the UV sanitizer. We tell them to clean their showers, and then we give them nutritional supplement like biotin. We should talk again. For make sure that they can have nice growth, strong growth for their nail. And what I do check before if they have any thyroid condition, hormone, heart, epilepsy treatment, because those can interact with the medication with the biotin. So you have to be careful about that. So to me, that's almost more as important as doing the treatment because they go hand in hand. If the patients are not doing these steps at home and helping the process, I think the failure rate will be much higher. Next, please. So yes, I do the fungal culture, not because we do this for over 30 years. You kind of have a sense this is a fungal nail, but sometimes when the result come back, it comes back with yeast or mold or bacteria. It's a mixed bag of things happening, and that drives my recommendation. So I could put them, and I'm talking about sometimes I do multiple treatment at once. They could be on the terbinafine and TOFX. So, or I can say because you have mold and yeast, I'm going to put you on fluconazole. So the KOH is very important. The fungal culture you get from your lab is very important to determine what is going there. Is it just T-rubrum? What is going there? So that will help me in making a conclusion for that specific patient. Next, please. Okay. So something else we find when patient comes in with fungal nail, almost 90% or more of the time they have a secondary tinea pedis, which needs to be addressed. And I usually prescribe a topical antifungal, usually clotrimazole, but very well, and very good clearance. If they on the terbinafine pill, for example, that clears it up as well, but they almost always get a topical antifungal to address the tinea. Some of them have hyperhidrosis. So I will recommend some kind of antiperspirant roll-on. And there is a compounding medication that makes one that I use. So I will prescribe that for the patient to use in order to help them, while they are spraying the shoes and cleaning the socks and everything else in their shower. I also address those things on the skin because we know that fungal infection travel from the skin to the nail and back and forth and back and forth. So we have to address it not only on the nail, but also on the skin. Next, please. Okay, so now how do I do this? How do I implement it? How do the patient buy into this? So we have a protocol, and the protocol really, it makes it your life very easy. I do a lot of the first visit, the last visit, maybe one in between, but it is really staff-led, and I have trained my staff to be able to do this. So an initial visit is a regular visit for any patient that will come in with the chief complaint of fungal nail that needing to be treated. Once we go through the whole process and they choose to go ahead to do TOFX as a treatment, then my staff take over. So the staff does all the treatment in between. If they need me to go in to do some debridement or they have a question, that will go in, and then they will have the final 10 visit with me where I give them post-treatment instruction, and then they'll have a follow-up to monitor in 3 months, 6 months, and maintenance. Okay, move on, please. Okay, so on the first visit, we have a consent form, and I highly recommend that you explain to the patient because we have to manage outcome. This is not 100% effective because it's a out-of-pocket expense. It's not a covered procedure. Patients are paying cash for this procedure. In their mind, in all my years of practice, they think it's going to work and they're going to be 100% result. So I told them no. I give them the different scenarios with the topical, with the oral, with a laser, with whatever treatment. Nothing is 100%. So they know that, and they sign a consent knowing that it is not 100%. Because otherwise, what's going to happen at the end of your treatment, if you have a patient, which we have, that does not do 100% better, they're going to be upset and annoyed. So they know that this is just like if they took the terbinafine, which we know that doesn't work for about 20%, 20 to 25% of the people that take it. It is the same process with that. So it's very important to go over the consent, the process, and the outcome expected. Then we document everything. We document as if we're doing any insurance claim. So we put, I'm big on documentation. So we document which toenail are affected, what's going on with everything. Then my staff take a baseline picture. This way we have it on file. This way, I want to tell you, when it's come to visit number 10 or number 8, they can say, I don't know. Then I like to tell them, let's roll the tape. We don't do that anymore because we're into 2026. So we'll pull up the picture and they will see the difference between their first visit and where we are today. So prior to doing the treatment, the nail has to be cleaned with alcohol, remove everything. Then I do the debridement. And then after I do that initial debridement, then my staff take over. Next slide, please. Next. Okay. Did you skip one? No. Yes, number 10. Can you go to number 10, please? Thank you. So the staff now does the next probably 9 visits, 8 to 9 visits, because they will add we have a 2FX template, procedure template that I've created that they will put up, and they'll put 2FX treatment number 1, number 2, number 3. They will clean the toenail as directed by 2FX protocol. They will apply the photosizing serum. It's blue. Okay, so the blue, I'm going to address that now because I don't think I addressed it further down in the slide. The blue is, for me, I explain to them, once in a while you have a patient that say, I don't want my toenail blue. The women don't care because it's like a blue toenail polish for them. Some of the gentlemen will complain, but the blue is also a marker for you to see the fungal load. So the deeper the blue, the more fungus. So this way we know, my staff will tell me we need to debride some more at the subsequent visit, or if it's lighter, you have less fungus in that toe. Okay, so they apply the serum, they let it dry, and then they go under the light therapies on a timer for 12 minutes, and then the patient goes. So the patient that are coming for 10 visits, they get up and go. At that point, we don't even the first time, we wait and tell them, okay, you're done. But most of the time, now after a while, they just get up and they leave. Very important. That's part of the guideline for the medication to work properly. I do not let my patient, I'm in Florida now, and they want to know, can they go swimming? For the first 4 treatment, the answer is no, because I need to see that blue from the serum to see how much load there is, okay? And so I tell them they cannot swim for the first 4, which is the treatment is every 2 weeks. And what is important for every 2 weeks, and Monica can correct me if I'm wrong, in the studies, in the lab, when they do the swab and they put the fungus, if you pass the 2-week mark, the fungus grows at a high rate. So you need to keep the constant every 2-week application to decrease that fungal load and target that fungus to get rid of it. Next, please. So this is the patient we said patient, as a matter of fact. You'll see patient came in, nails is thick, ugly. She doesn't like it. She's a young lady. She's in her 50s. And so she didn't want to take any, she's young, but she didn't want to take any oral for any reason. It wasn't contraindicated for her. She tried a lot of treatment. The nail is very thick. And we're in treatment 7, you see, and the nail still look like it's thickened, no matter how much we debrided it, and then it's still darkened. So at that time, we decided to do a nail avulsion because I've only have 3 applications left, and I didn't feel confident that she was going to get a good result if we did not remove the toenail and and to apply that serum directly. And you see that was after the last picture is after we did the avulsion. And I want to tell you, you can use the 2FX even if you remove the toenail. I waited 2 weeks because she came 2 weeks after anyway. every 2 weeks she comes. So this is the visit after. And the nail is looking very thin, much thinner. She's very happy. And she just finished her last treatment and she's due to come back in 3 weeks. So the nail is going already and she's very happy with what it looks like now. So sometimes you do have to make a decision about removing the toenail before applying or just do it and just make sure you do a lot of debridement, very thin, very, very close debridement, because otherwise the nail is going to still sit too thick. And sometimes the reason that I do that is because patients are pain. When we do the debridement and I'm not even where I'm supposed to be and they complain, it's hurting me. So I'm like, the easiest thing to do for the patient and for you to get a better result for them is to just remove the toenail. Next, please. This is the patient. She's very happy. This is one of the first patients I did when I first started with doing toe effects. She was very concerned with the way the nail looked with the dystrophic area, and it was going down the center. So this is the progression. The first picture is the first treatment. The second one is 7th. And then she came back 9 months later, and look how beautiful her toenail look. She was very happy. And she was one of those people, the husband came with her at every treatment and sat with the treatment room. And I was like, oh, you better work, because that man was really anxious about this toenail. So I was very happy about the great results, and she's very happy with the treatment. So you can see the progression very clearly. So I gave you one of everything. So next slide, please. So this is a patient. Okay, so the protocol is every 2 weeks for 10 visits, and there is maintenance that is recommended for the patients. And I'll tell you what I give them to do if they're not doing toe effects every 6 weeks. Some of them don't want to spend the extra money after they spend for that. This patient is a patient that, this is the perfect number one. This is 3 months later, is up on the other side. She voluntarily asked to do another set because she felt that her nail looked better. They felt better, but she felt that an extra 10 session will get her to where she wanted to be. So I was like, wow. So when the patient go through the process, they see how easy it is, and they've been battling, most of them, onychomycosis for a long time. So she wasn't clear totally. I give them work, I give them homework, I call it. I give them topical to do in between after the 10 treatment. I'm like, you have to do maintenance, you have to still put your shoes. This is not like hello and goodbye and come back is going to magically. So they do have maintenance care to do. So she came back 3 months later, and the nail, even though it looked better than initial, but she was like, she was satisfied because, like I tell you, I managed the expectation, but she signed up for the 10. She goes, that's it, you can do a few. She goes, no, I want to do a whole 10 set. So that was one of the patients. So I wanted to show you that not everybody's 100% like my first patient, but you'll see the data as, next, please. I'll talk about that in a second. So this is one of the severe cases. There's the last one. You see the treatment number 1, treatment number 4, and treatment number 10. How much better it looks. So I'm very happy with the treatment, and the patient, more importantly than me, the patients are very happy with the outcomes. Okay, it's okay. So far, I've treated around 50 patients in the practice, and we have 82% success rate. 41 patients are very happy with their treatment. I want to just show you the happy, everybody's toenail is clear. I wanted to show you the ones also that you're aware that not everybody is going to be clear. Of the 18% that did not clear, 2 showed improvement, but it wasn't resolved. But they were happy that it looked better than before. Some of them had clearance, 16% had clearance for 6 months, but they experienced recurrence. Like I said in the beginning, you have to do most patients, I explained to them, are genetically predisposed to fungal. They don't have enough, their immune system is not fighting it. So they're going to have it again. So I tell them, it's like you're having an abscess. Does that mean if you take an antibiotic, you're never going to have an abscess again? So in patients' mind, they think just because I treated, I could never have another fungal culture. And I tell, infection, excuse me. And I tell them that is not the case. You can always get recurrence, but you have to, that you have a problem with fungal infection. So therefore, you need to spray your shoes, you need to wash your sneakers, you need to change your socks. So those are the things that will help them in prevention, not 100% prevention, but help with the recurrence rate. Next, please. Okay, so this is about, yes, so I kind of talk about that. 10 treatment every 2 weeks. The 12 minutes per treatment is really quick. Sometimes it takes us longer to bring the patient back than to actually do the treatment. And then I tell them it takes the nail 12 to 18 months to fully grow out. And then we can make an assessment then. The same way I will not give them terbinafine for 12 months after they took the first set of terbinafine is the same way I do the TOFX. Unless the patient, like the patient before came 9 months later, she wanted it, 3 months later, she wanted it again. But I tell them there is a hole, then it takes 12, 18 months to fully go this way we can see the full effect of the treatment. Next, please. Okay, so I just put this in because most of you who are on the webinar, this is a non-covered procedure. Patient pays out of pocket. The average price for TOFX is $1,500, and it's for the entire 10 visit. In our practice, we do not charge per visit because I tell my patients it's a treatment plan. So if I let a patient pay per visit, the likelihood of them skipping treatment is very high. They might say, I'm not paying, I'm paying this month, I'm going away. So in our practice, the patient pay the whole treatment plan one time at the first visit. They get all of their 10 appointment for them to follow if they have for any reason. So we try to manage it from that window. If they have to change one day to the next, it's almost if they go 3 weeks, it's like starting from scratch. So the patient has to understand that the result is not going to be the same. So we manage this treatment plan from the first day we start, and we manage the expectation the same way as well. So if, for example, in this chart, if you thinking or if you have this device and it's 5 patients at $1,500 for the first month, you make $7,500. And if you have 5 patients every month, your yearly will be 90, and so on and so forth. So you can see there's a potential for a lot of non-insurance based revenue in the practice. And it is another treatment method that you offer your patient. And a lot of them opt for that treatment because they have kidney, liver, heart condition. And those are the reasons most of the time I don't give my patient terbinafine or fluconazole if they have those medical condition or they have a polypharmacy or a bunch of things they take in. Then they say, and some of them they just don't want to take any pills. They're like, and then, or if they want to drink, some of them like, if you're taking the terbinafine, you cannot drink because and they're like, oh no, 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 no. So they will opt for TOFX. But I'm very confident in offering that treatment option to the patient because I've seen the result and it's very effective as long as the patient follow the protocol that is given to them. Next slide, and I think that's the end of that. Next. Thank you. Now, I welcome any question that you may have. If anything I didn't cover, I'm happy to answer the questions.
All right. Wonderful. So let's see here. I just want to tell everybody, put your questions into the Q&A box, and we're going to get to those in just a second. I do have a poll with a few questions. So I have one poll and then another one. So let's launch this poll while everyone is typing in their questions for tonight. All right, so you should be able to see a poll here with 3 questions. So let's just take maybe 30 seconds, just answer whatever comes to your mind first is the right answer. Okay, good. All right, and I see some more questions coming into the Q&A, so this strategy is working. All right, good. So we've got some pretty good participation here. I'm gonna give it 5 more seconds, and then we'll end this poll. Okay, great. So can you guys see those results to the poll? interesting. I'm sure, polls are always funny because uh, obviously the most common answer stands out. Usually there's a clear front runner. Here, a couple of these are pretty close though, so it's always interesting to see what people are experiencing in their practices. All right, so I am going to stop sharing that poll and let's flip over here to these questions. Let's see. I will read them and then either one of you can jump in to answer. Was there testing of the nail plate via fungal culture or PCR, and what were the fungal organisms present and at what percentage? That was at 8:15, so it was probably one of your earlier slides.
I can talk about that from the study. So yes, every single nail included in the study had usually fungal culture KOH done. I think some of the later ones had PCR. The most common organism was our friend T. rubrum.
Same for me, T-rubrum in practice.
Okay. Let's see. Oops. Does it kill yeast or mold as well?
I can take that too. So the TOFX is agnostic to the pathogen, so it doesn't matter what the pathogen is. It's not a systemic, so it's not tailored to any particular organism. What it does is it has a particular affinity for the fungal wall. So yes, it will yeast, mold, all of it. It doesn't matter what it is. The light therapy is agnostic to the pathogen. So yes.
Wonderful. For oral combination, using terbinafine 250 daily and diflucan once weekly at 150, or is the second med intraconazole 200?
I use fluconazole most of the time, and it's 150 weekly. Actually, I do it I tell the patient to remember Fungus Friday on Fridays. So I usually do terbinafine 250 for 90 days and fluconazole once weekly on Fridays for 12 weeks. And that seems to.
Okay. Great presentation. I especially like the business insights. Are there any other business insights you would like to share?
You can call me because I don't know exactly what he wants. I can go into detail how we advertise. Marketing is important. When I first started, my practice did an article about TOFX in the local health newspaper, and that was our initial launch. And a lot of patients saw that, and they came in with the article with them, and that was the beginning of how we started with TOFX. Now it's like they know that down, where I am with the office that do TOFX, so patient come for that. So that's the first step is people to know, for patient to know that there is a treatment option called TOFX light therapy, and that you are the provider that has that offer that treatment plan. So that's the marketing aspect. And then, like I said, the rest is we do every day, all of us, because we practice, so we know all about onychomycosis, the difficulty in treating it. And then also is to be confident in the way you explain it to them. I never force them to get to FX. Like I said, it's one of the treatment options that I give them. And some of them will say, I would love to, but I don't have any money. And I'm like, I'm sorry to hear that, but we'll do everything we can with the other treatment. I have a whole sheet that I tapped up that's called the Fungus Bible in our office that we hand to the patient. If they cannot afford to buy fungal soap, for example, we tell them to soak with Epsom salt and apple cider vinegar. So we try to help every patient that they feel that we care about them as an individual, but not because we're trying to sell a treatment that is cash pay. So if you give that patient that confidence that you care about them, that's the best thing you can do. And then they will pay the money as they feel confident, or they save the money, or somebody will give them. So I wouldn't push the treatment on them, just it's an option in the options that they have.
All right. What can we use to do in-office testing for fungus?
I don't do any of those. So years ago, umpteen years ago, we had the little tube we used to be in office. I don't think there is such a thing nowadays. There are some companies that offering that you can have a lab in your practice. That's something if you want to do, if you have a lot of onychomycosis patient and that's primarily your practice, you can look into that. But I don't know of any easy test unless you get your lab out. When I used to do clinical studies, I used to have my lab. I used to do the slide. I used to look under the debris under the microscope, but that is time consuming. So I don't know if it's how feasible that is to be that is sustainable and cost effective it is to do that.
Any reactions to the serum on the skin tissue?
So far, no. From my experience, the patient has not complained from any. They'll have reaction, believe it or not, with ketoconazole, with all the other topical, but I've not encountered any with the serum thus far.
And I could also add there, so we need to monitor this as a medical device company. We need to monitor adverse effects, things like that. I mean, localized reaction to any topical is possible. We have not gotten any reports. Not saying it's impossible, but we haven't had any.
All right. What frequency light wave is used?
Shall I take that one, Patricia?
Yes, because
Oh, okay.
that's your
Yeah.
wheelhouse.
Yeah, so it's a red light 660 nanometers and blue light 405. So each frequency has its own job to do.
How often do you do maintenance therapy? It says, how often do you do maintenance therapy and how often? So I'm guessing the question is, do you do maintenance therapy and how often?
The recommendation is after the 10th visit, patient can do monthly or every 6 weeks therapy. Only two patients have opted to do that. Some of them, the toenail looks great. They've already paid their $1,500. So I do give them a topical, a compounding topical to do after their last treatment, to do twice, two times a week. So therefore, I don't have too many people coming back for the maintenance, like only two people. And then I have the other another two that are doing full toe effects again because they opted to do full toe effects every 2 weeks as opposed to a maintenance. It all depends on the patient and the outcome. When you do the 3 months visit, you can recommend or not recommend.
Do you use a topical while the patient is on TOFX?
Ah, good questions. I'm going to say 95% no, but I'm doing an experiment right now. I know, full disclosure, I have one patient right now that I'm putting topical after the fourth visit. It's it's a problem. So I'm doing a compounding topical with that patient because I'm experimenting to see what is the outcomes going to be. So to be continued. I will let you know what's the difference.
All right. Uh, what was the percentage of T. rubrum and what other organisms were present?
In my experience, almost 90 and up, C rubrum. And you'll see mixed. You'll see mold, you'll see yeast, maybe another 5%. Sometimes you see mixed bacteria, maybe because the toenail wasn't cleaned properly before we took the sample. But almost 95 and plus is T rubrum, most likely.
I think that was the case in our studies as well. We also run a diagnostic service, so we do PCR. And what's interesting is that I know a lot of the results over the summer are coming in with as non-dermatified molds more than usual. And the working hypothesis is just people are out in their gardens getting exposure to all kinds of organisms that you might typically find in soil, animals, being outdoors. So it can be seasonal, but that's just a fun fact for the summer.
Is this available to DPMs in California?
Yes, everywhere.
Is the light therapy a cytal or static mechanism to pathogens?
I am sorry, I don't know what that means, so I can't type that
Cytal
for you.
spelled here Cidal, so I might be pronouncing it wrong.
Okay, does it kill? She's trying to say, does it kill I'm going to go by that. Kill the fungus, or it just make it I'm going to static, like it's just I'm talking about my English word. Okay, is it bactericidal? That's what he wants. Fungicidal. That's what I'm getting from the question. Am I right? If it's fungicidal, does it kill the fungus? That's what he's trying to ask. Whoever's asking.
Oh, okay. So it's how it works. It has the you activate so the light activates this serum that adheres into the fungal cell wall. So this serum has a particular affinity for the fungal cell wall. It will bind to the fungal cell wall, which sets it apart from other molecules. And then the light, when you run it, it creates reactive oxygen species, and these will go and attack the fungal organism. So it is fungicidal.
Is it oxidation therapy? It's just by oxidation, not by heat, like a laser. So the
No, not by heat. So yeah,
no, that's what I'm saying. It's not heat like laser. It's oxygenation.
yes,
The oxygen in the air with the light and the serum.
yes.
Okay. What is the life expectancy of the light device and the cost? We already discussed the cost. What is the life expectancy of the device?
5 years.
All right. Will ToeFX continue to work and kill the fungus for the entire 9 to 12 months if the patient only does the 10 initial treatments?
Your study? I would say yes. Because, so the patient that I show you the clear nail in my slide, that was 9 months, and she didn't do anything. So nine months later, her toenail looked very clear and very beautiful.
I think based on our clinical results, it really depends on the severity and what's going on with the nail. So it's important to monitor. The thing we were looking for when we were running the trial is how fast is that clear nail coming in? That's really what we're looking for because the rest of the nail is dead. If after 3, 4, 5 treatments you're starting to see a couple of millimeters come in, you usually will see this continue, but the key thing is you've got to get under the nail plate and get the organism dead. So if it's dead and you see it coming in, you see the clear nail coming in, it will, yes, after 9 to 12 months, even if they only do the 10 initial treatments, it should be a successful course. But it's very hard to tell. You can use the severity as a gauge there. If it's super severe, it's unlikely that only a couple of treatments are going to finish this organism off.
How do you explain or differentiate this light therapy versus the other treatments with your patients?
Just like I said earlier, I explained about, they all know about topical or topical works. I go step by step with every treatment, and I put them in 4 categories for the patient. I said, we have topical, we have oral, we have laser. You can talk about laser if you choose to. We don't do laser in the practice, and I tell them that. We have the toe effects, and we have surgical removal of the toenail. That's how I approach the treatment with the patient. So I explain it to them separately with their success rate, 30 to 50, 60, 70, 80, and the side effect and the benefits of each. Some patients have to have their toenail removed and apply topical because they cannot afford the toe effects. Some patient wants to take the pill and say, let's see how it goes. Then if it doesn't work, I'll go do toe effects. But I just like what about the toe effects by itself? I just explain all the treatment like you will do if you didn't have the toe effects as an option. And then I explain about the two effects, how it works, like we just said before. It does by with the light, with the oxygen, and all the treatment works. Or can they have to come? Why they have to come every 2 weeks? Because if they don't come on schedule, the fungus goes faster. Step by step, explain the process to them exactly like I did to you. I do the same thing to my patients, and then they can make an informed decision if they want to try the treatment.
Why did you exclude the diabetic patients?
That's a really good question. That was a point of discussion for Dr. Rabinovich and Dr. Wismer, who were the lead physicians on the study. I think The main reason was it's if I think if we could go back in time, Dr. Wismer was really pushing to include controlled diabetics. It was the risk of having uncontrolled diabetes that was an issue at the time. That said, I think we'd love to explore just doing a study on diabetic patients. I think there would be a need.
In my practice, I include all the diabetic patients. So I don't exclude diabetic. And I've done diabetic patient I've cleared.
How much are vials of serum after the introduction pack?
It's a pack of 10 for 200.
All right. What is the compounded topical that you use?
Oh, I guess that's for me. I use EBM, the company EBM. If you have not heard from me, they do compounding. They're based in Tennessee, and they have a few formula. EBN N45, who has the topical terbinafine, your ketoconazole, all kind of different ones. So I choose one of them based on the patient, and is a liquid. So for better penetration than cream. Sometimes the patient don't have coverage or they cannot afford to pay more for any reason. So I've used cycloparis. I want to tell you, I'm not a big fan because of the layered thing. Efinaconazole is not covered most of the time, at least in my area. Patient has a $400 copay most of the time, even if you get prior authorization. If you can find any topical liquid for penetration that you can give the patient that they can afford, because you have to manage that too. I'm big on SDOH, Social Department of Health. If they can afford to pay for it, you should give them a topical. That's my recommendation.
What is we already asked that, compounded topical. And I have the TOEFX and I've seen great results. I live in California, so thank you for that comment.
Yay.
Uh, Reinfection of onychomycosis is so very common. Studies show how the fungus can live in shoes for nearly 20 months under the right conditions. How much time do you spend educating patients about how to prevent reinfection? You mentioned fungal Bible, clever name. Can you explain that further?
So I have a page, it's like a two-pager. So it tells me about pedicures, how to clean their shoes, their showers and everything in so the staff knows to pull it out. So for the shoe part, we tell, and our sneakers, our books to work. So I washed my sneakers in the wash regularly because I deal with fungus every day. Even if the dust and I'm afraid to get the fungal infection, I tell you. So I tell my patient, I wash my sneakers, I expect you to wash your sneakers. And I do recommend fungal soap. Nobody's paying me for this, just full disclosure, just the product that I use. For years, I've used fungal soap in my previous stuff in New York. So I put that as detergent in my washing machine to wash my sneakers. So I will tell them they can do that. I also recommend spray, like Lamisil spray, Tenactin, based on there's Dr. Antifungus spray. There's so many other sprays. And I also recommend the UV light. There is TerryShoe, there is Pedifix has one too. And I tell them to go Amazon and buy it and I tell them they need to continually do this. This is not something I tell them they need to discontinue after the treatment. I explain to them they can get reinfected, that they need to clean their shoes. If the shoes are not washable, they spraying, the Lysol wiping, they using the UV light.
Where would we purchase the unit? And after 5 years, do we need a new system or do we upgrade the light unit only?
The unit you can purchase, just go on our website. I don't know if Anne is sending a link out on how to contact the team afterwards, but on toefx.com, there should be lots of forms or just email info.toefx and someone will get back to you almost right away. So directly from the company. And how many treatment cycles? Oh, sorry. Where after 5 years, do we need a new system? I mean, 5 years was based on our estimate of the LED lifetime. So about, I think it's 50,000 hours, which is a lot. You have to do a lot of treatments for that. So we've not really run into it. I don't know. I'll let you know when we get there. So far, people have gotten a lot of longevity out of these devices. So I don't know. Give us a call and we'll try and help you out if the lights burn out.
All right, and I just put that info email into the chat, so everybody should be able to see it. And I do have another link that I'm going to share in just a minute.
Thanks, Sam.
Um, you mentioned that the device will last 5 years. How many patient treatment cycles does that include per year? If you use it on 50 versus 300 patients per year, would the lifespan not differ?
Absolutely. If you're a very heavy user, the device will expire faster. If you're a light user, it will last forever. But I think there should be enough in there. I mean, if a patient is sitting in total under the light for 5 hours over the course of a treatment, and I think even that's excessive, but over 50,000 hours, you should get 10,000 patients out of it. So I think you're good. The FDA makes us put in a lifetime, but I think it's a very, very long-lasting device. So far, and this has not been an issue.
All right. And so I just put into the chat another link for anyone to follow up if they want more personalized answers. They can reach out to you guys and book a meeting. Does the light therapy kill fungal spores since spores are a major cause for reinfection?
Oh, good question. Spores are difficult. They're very difficult. So there we did not take, when we did the clinical study on nail, it's very hard to see if there are spores in the nail plate. But we did in vitro studies, just growing the fungal organism in petri dishes. And in that set of circumstances, the spores were gone. So yes, I can tell you the in vitro results. In vivo, a lot harder to see the exact fungal structure under the nail. So hopefully that helps.
Is it one vial per person or per treatment?
per treatment. There is 10 in the pack, so it's 1 pen per treatment. Because you're applying 3 layers. We didn't go into this specific, but every pen you're applying 3 layers at every visit. Even though there are some in the tube left, you'll be tempted to use it more than once, but you don't want to be reinfected by brushing over and over with the same pen as before. So the recommendation is 1 pen per visit, and there are 10 in the pack.
Wonderful. All right, so I have one more poll, just real quick, and I see that we've got another question. So if you have any follow-up questions, put those
Into
into
that.
the Q&A now, and I'm going to start this poll here.
I'm going to quickly answer those 2 questions. You treat all the toenails, no matter if they're infected or not. Okay. And there is enough in the vials to treat all 10 toenails because there are 10 pens, and each pen is for all 10 toenails at each visit. So that's that.
Wonderful. All right, so I did just put another poll up. Just if you want to receive more information, they can send it to you directly. And so just click yes, and we'll get that over to you. And okay, looks like a lot of people have answered. So I'm going to just, oh, we've got a couple more coming in. All right, good. Let's see, did we answer all of our questions? Yes, we did. Okay, super. So I'm gonna let this poll kind of roll for a second. Poll roll, that's funny. And I want to thank our sponsors. There's another question here. How much time per treatment?
Okay, the light itself take 12 minutes, but the prep before, because when the patient comes in, you debride in, it's depends for fast to debride the toenail, you wipe with the alcohol, they wait, you apply this. So that's the staff doing that is not you doing. So I don't even count that as part of my time. So it might take another 10 minutes before they do the light. So I schedule them every half an hour. That'll be plenty sufficient of time for from start to finish.
Awesome. All right. So I think that's all of the questions. Again, if you have anything else, you can surely email me and I'll pass it along. And I just want to thank our sponsor, ToeFX, for being here tonight and sponsoring tonight's webinar. And thank you to Dr. Nicholas for presenting. It's a lot of time that, goes into putting together a presentation, and then also being online at 8 p.m. at night is not everyone's favorite thing to do. So thank you very much. I appreciate both of you. And we do have other webinars coming up. So just, keep an eye on your email inbox. I'm sure you know I'll never let you forget about an upcoming webinar. So thank you, everyone, and good night to everyone.
Good night. Thank you.
Thank you
Good
so much.
night. Good
Thank you.
night.
Good night.